I've been in Chicago, Midwest Orthopaedics Rush since 1997. I was in Milwaukee, Wisconsin before then. So these are my disclosures. And really what I'm going to talk about today really is something different because I've given this kind of talk before about work harm injury. Or obviously I'm going to make a lot of comment about that. But really I want to talk about lumbar spinal disorder as I see it as a clinician, and maybe talk about kind of exciting future treatment, if you will. So hopefully, it's kind of like a little echo going on. All right, so just get everybody on the same page. We're talking about lumbar spine is a big social economic impact, as you all know. And what I'm going to talk about is some of the common diagnoses I see that require surgery, such as HMP, spinal stenosis, and instability problems. And since I do a lot of teaching and research at Rush, I'm going to share some of my research last 10 minutes of my talk. So I'm just going to talk about briefly about HMP, herniated disc and stenosis. It's actually very easy to diagnose HMP and stenosis because they come in with a specific clinical presentation. If the patient has back and buttock and pain going down the leg, down to the big toe, I know before I even see the patient it's an L5 radiculopathy until proven otherwise. And then obviously we do a specific examination to confirm that and correlate that with imaging. If I have a 70-year-old coming difficulty walking and kind of pain going down the legs, that's spinal stenosis until proven otherwise. So I spend a lot of time talking to the patient about clinical presentation because that's kind of what drives your treatment. And obviously, all these spinal diagnosis, first line of treatment is non-operative. Whether it's HMP, spinal stenosis, a lot of them get better with injection and physical therapy, what have you. So really, surgery is the last step. Just want to let you know. There are some exceptions. Obviously, if you have a cardiac quinet syndrome with bowel and bladder and significant motor deficit, that's a surgical problem. Everybody recognizes that. So I think that's a sort of textbook teaching about the spinal diagnosis. This is annoying. All right. Just want to give you a little diagram about not every spinal stenosis is same, because if you diagnose spinal stenosis, it can be central. That causes that spinal stenosis neurologic complication. If you have a lateral recess where the nerve obviously exists, if that's trapped in the lateral recess, that causes a radiculopathy. And finally, as the nerve exits, it goes into what we call foramen. So that nerve is very long, so it can be impinged proximally, distally, or sometimes both. And once again, I see a lot of second opinions, and some patients are diagnosed at one area, but imaging studies were not good enough. They don't diagnose another area of compression. Then you can do surgery, actually, they don't get better. Like this patient, HMP is very easy to identify at L4-5, that actually impinges the L5 root. But the same patient, same level, different level, L5S1 is impinging on the L5 nerve root. So this patient, if you just had a disc surgery at 4-5, not take care of this foraminal stenosis, patient will not get better. So once again, the accurate diagnosis is very important and correlate with the spinal imaging. So what we do at Rush is actually, because spinal imaging is getting better and better. Nowadays, you got the standing MRI scan, CT scan with 3D, all that, which is all good. But as you know, spinal problem is dynamic in that when you get an MRI scan, you're lying on supine, but a lot of patients have pain when they move. It's a dynamic problem. So we don't know that dynamic nature of a spinal problem. So I've done a lot of research with collaborators at Rush. We are three-dimensionalizing a lot of the anatomical structures, such as the ligamentum flavum. Even nervus can be three-dimensionalized, so you know precisely where it can be pinched. And we actually have a kinematic study where a patient can be in different position, how that affects the pain and so forth. These are all investigational in nature. So hopefully in the future, we can get a better sense of patient symptom more accurately, because correct diagnosis obviously leads to correct treatment. Okay, my talk will take longer because of one diagnosis I want to just be aware of is a congenital spinal stenosis not that well diagnosed or even well treated. Because everybody has everybody is born with a different canal diameter, right? So if you're born with a very small canal diameter, then they develop the spinal stenosis kind of early in life. So this can be a worker's injury patient. They happen to have a very narrow canal to begin with, but after 4 years of wear and tear, now have a disc bulging, they have a problem with spinal stenosis. And if discogenic painful inflammation, if the disc is causing, it's worse with sitting. Now, if you are sitting having back pain, it's disc-related pain until proven otherwise. Spinal stenosis pain is worse with standing walking. So these people will present to me back pain, but their back pain is not typical. Doc, I can sit for a couple hours, but I cannot walk in. It's just like an elderly spinal stenosis patient. These are people with congenital spinal stenosis. Overlooked, almost never diagnosed by a typical physician. And in fact, we published this article in 2005 to be aware of this diagnosis. Because the problem is a patient gets injured, right? Congenital spinal stenosis get injured. And guess what? You got a back pain, and they get fusion. They get even worse. You should not do fusion on a congenital spinal stenosis. If you're going to do operation, you need to decompression. You're going to give more room for the nerve. So once again, correct diagnosis leads to same treatment. Congenital lumbar spinal stenosis, I do IMEs sometimes, and second opinion, this is more common than you think. So this is actually a patient I operated on, father and son. And congenital spinal stenotic are usually what we call quasi kind of achondroplastic. They are like, stocky, more male, and they have this, and they suffer with the stenosis. They have a, degenerative bulging disc, but they are congenital spinal stenotic. So look at that L4-5, very narrow. I mean, this is a 44-year-old person. This is not 75-year-old with typical spinal stenosis. That's the point I'm trying to make. And I diagnose congenital spinal stenosis 2-3 times a month. So it's not rare. I mean, it's not common, but it's not uncommon. That's the point I'm trying to make. Okay, so what do you do when you diagnose herniated disc? Once again, conservative treatment. Indication for surgery is clear-cut. They have to have a leg pain. You don't operate herniated disc for back pain. It has to be that nerve root pain. And they have failed conservative treatment. They went through the proper conservative treatment. They're still having quality of life issue, work issue. That's when you operate. If you operate in that setting, there are many level 1 studies that we participate in national trial. They do fine. High impact journal like JAMA. And I was actually honored to be part of the study that involves spinal stenosis patient. It was published actually in New England Journal of Medicine 2008, and showing that if you do surgery for spinal stenosis patient in that setting, once again, patients actually do better than non-operative treatment. So we can confidently tell a patient that surgery is a good option if you have a proper selection criteria once again. Nowadays, you can do surgery in different ways. Obviously, MIS, minimum invasive surgery, is common. And I'm all for MIS, but one of the problems with MIS is it's very technical. So if you don't know how to do MIS properly, if you do not adequately decompress, and patients not better even after MIS, that's not good, right? So you have to get the job done. And key to spinal stenosis surgery is two things: adequate decompression and preserving stability. You can do a decompression, no problem, but if you take out all the facet, cause instability, that's not good. But if you do not adequately decompress the compressed nerve root, that's even worse. Patients know better. So there are ways to preserve important structure. And I'm not going to go into different technical surgery, but once again, if you identify correct pathology, do the right operation, whether it's an open surgery or MIS, patient will have a good outcome. So really, it's a no-brainer for herniated disc and spinal stenosis. If they have a good outcome, they will do better. Now we get into some other diagnoses that require bigger operation called spondylolisthesis. Not only about spinal stenosis, now vertebra is unstable, now shifting, right? We call that spondylolisthesis. And for this operation, for this condition, you need a bigger operation called fusion. And you're gonna hear so many different ways to fuse a spine, whether it's T-lift, posterior MIS. That's not that important. Once again, you have to do the right operation with the right technique. But bottom line is that every spondylolisthesis is not the same, because some patient comes in with a significant instability, some patient comes in with a minimal instability. So I tend to individualize. If I have an 80-year-old person with a minimal instability, I don't necessarily do a fusion. I do a decompression. And I tell the patient that you may need a fusion down the road. More often than not, if you do it in a less invasive way, they do fine. So what I'm saying is that individualized based on patient's obviously clinical characteristic. Same for degenerative scoliosis. I mean, as a workers come, you're not going to see this, but we see this all the time. We see elderly people, whether you're 60, 70, 80, they come in with a curvature, stenosis, everything I talked about in combination. And there are so many ways to treat this type of problem. What I see quite often, once again, second opinion, is too much surgery. I mean, you got an 80-year-old, they're gonna get a, top to bottom major instrumentation fusion just because you know how to do that. So I once again, my teaching is individualize these people with, because everybody has a different degree of scoliosis, different instability, and you could individualize. When one of my fellows looked at my cases a couple of years ago, really third of my patient had just a decompression without any fusion. Third of my patient had what we call local fusion because they has a spondylolisthesis. And third of my patient had a big operation because they came in with a major deformity. So it's not a cookbook approach, it's an individualizing patients. So this just to give you an example. If you look at this patient with a scoliosis, stenosis, obviously failed conservative treatment, a lot of spine surgeons, right or wrong, will do a major fusion, L1 to sacrum fusion and decompression. I'm not saying that's wrong, but this patient has minimal back pain, mostly leg symptom, so I elected to do just a decompression. Careful laminectomy at 3 levels. Patient is happy, overnight stay. So what I'm saying is that you can treat these people even with the scoliosis, not too severe stenosis, without another. You see, this is a laminectomy. And I tell the patient that after laminectomy, you may have to come back if you develop instability 2, 3, 5 years down the road. Of course, they come back once in a while, but not that common. 90% of the time, they are fine. Another patient with right-sided radicular symptoms and just require less surgery, because if you, once again, even fusion can be, if you do decide fusion, the next thing to discuss is, are we going to fuse 1 or 2 levels, or am I going to fuse the entire scoliosis? Once again, I have the teaching method for that. Once again, it's all about the patient symptom. If the patient symptom is coming in the L5S1 with L5 radiculopathy, patient had scoliosis for the last 20 years. That's not their problem. So a lot of doctors tend to look at the X-ray and treat the X-ray. My recommendation is treat the patient's symptoms, follow the X-ray, and take care of their problem. And particularly for elderly people, less surgery is better than big surgery. So that's sort of my bottom line. So this patient only 2-level fusion rather than fusion all the way down up to T12. Likewise, this patient is a little different. You see, this patient is not just a degenerative scoliosis and radiculopathy. This patient has a deformity. This patient is not telling me, Doc, I cannot stand up straight. I'm leaning forward, leaning to the left. You got a lot of back pain. So this patient has stenosis as well as deformity. So you can make the same mistake. If you just do a decompression in this patient will get worse. So you can actually make a mistake of doing under treatment. So once again, it's the doctor's art to diagnose, what the problem is and treat it accordingly. And this patient had a big operation with this surgery. You can see there's a lot of metal, straighten the spine, You could say, wow. But this patient actually is doing excellent. This patient actually came from Phoenix, Arizona. I don't know why, the patients flew all the way from Arizona. There are a lot of doctors there, but came to me, had this surgery, and patient is doing excellent. So this is even worse problem. This patient has a previous surgery, severe what we call flat back. The problem is deformity is not just side to side, it's front and back. And if you have a front and back problem, we call that kyphosis, major problem. We have to correct that. So next, see, I think, okay. And then this patient ended up with the big revision deformity surgery like this with a pelvic fixation. But I'm going to discuss next 10 minutes about discogenic back pain because, every day is so common. Everybody has a back pain. There are thousands of treatment out there, chiropractic, physical therapy, acupuncture, injection, surgery, and all that. So nobody has a solution. I don't have a solution. It's a big problem, right? And typically, as I said, disc-related back pain is worse with sitting. That's how they present typically. Because as you sit, intradiscal pressure gets high, so everybody knows that. And typically, if you get x-rays or MRI scan, it will show aging changes, degenerative wear and tear changes. And we don't even know which disc is actually causing the pain. It could be one disc, 2, 3 discs, right? And not to mention, if you have a disc pain, maybe you have a facet pain as well, because the facet joint is in the same motion segment. So sometimes it's not easy to distinguish facet pain versus the disc pain. So it's hard to diagnose accurately, let alone treatment. That's the state of the art even today, back pain. I'm not talking about nerve compression, just back pain. And there's a potential for abuse, Well, anyway, so let me just sort of weigh in my sort of thinking about this discogenic pain, how I take care of it. I think the majority of patients with discogenic pain is non-surgical. I really recommend aggressive non-operative treatment because if everybody kind of takes care of themselves, it's not just a patient, physician-driven, it's a patient-driven. If everybody lose weight, stop smoking, which also affects the disc degeneration, get into core strengthening exercise, and stay away from narcotics, they will get better. Not everybody, a lot of them. So I spend a lot of time who comes in to have an operation. I spend more time with those patients to talk about non-surgical method than actually surgery patients. Surgery patient is easy. You got they are suffering, book them for microdiscectomy, whatever. It's these people who's been suffering for 1 year, 2 years. It could be work or not work related. It's a problem. It's a controversy. I'm not saying I'm right or wrong, but I'm on the sort of conservative end in terms of surgery for this patient. The reason for that is I can do the surgery. Surgery is easy. It's the outcome of surgery is iffy. I can do a perfectly looking, instrumentation, fusion, X-ray looks beautiful, but patient, they get better, but not at a 95% rate like stenosis or HMP. They get 50%, 60%. Going back to work is an issue when it's an issue. So spinal fusion, we do it once in a while, and some of the spine surgeons do more. They're not as conservative as I am. That's fine, but I always tell the patient that spinal fusion for discogenic pain is a last resort. So if you try everything else, you truly fail. And if the patient knows that you have a 60% chance of getting better, then you sign up. I mean, that's how I practice. That's how I teach my resident fellows. Artificial disc is something new and sexy, but it's basically you're replacing one of the 3 discs. As I told you, motion segment is a facet joint, 2 of them in the back, disc. So even if disc is causing the problem, if you only replace one disc and leaving the facet joint alone, it's kind of iffy. As an orthopedic surgeon, we know when we do a knee surgery, there's a uni-compartment problem. We do our uni. You have to have other compartment pretty healthy. So you're not going to see a lot of patients with advanced disc with a very healthy facet. So patient selection is very important. Number 2, how long it lasts is an issue. Because we replace the knee, it lasts for 15, 20 years, they're fine. You're talking about 30-year-old, 40-year-old, more active people. how long that's going to, FDA okayed it after 2 years follow-up, not after 20 years. So longevity is a concern. And then if you do artificial disc surgery, you have to do a perfect job. We know that anything we put in the knees or hips, varus, valgus, everything has to be anatomically correct to have a longevity and better function. Artificial disc, same thing. And when you go anteriorly, particularly adult 4-5, vessels in the way, it's sometimes hard to put that artificial disc perfect. So there's so many negatives. I'm not knocking down artificial disc. I'm saying these are the issues, not to mention the diagnosis and outcome. So when they do an artificial disc comparison study with a spinal fusion, that's how the FDA approved artificial disc. It's no better, no worse. It's about the same. It's a non-inferiority study. So they get approved. What did I say about spinal fusion results? About 56%, same with artificial disc. So it doesn't improve the outcome. It's just a new and sexy way to take care of discogenic pain. So don't think the artificial disc is a cure for back problem. So this kind of slide that I use all the time, because disc degeneration is not all a non-phenomenon. It's a gradual process. It can be very healthy, right? Or it can be at the bottom, grade 5, with bone to bone. But there's not a good correlation between patient's pain and the grades of disc degeneration. That's number one. So you can look at, bad-looking disc. Actually, may not, I see patients all the time, bad-looking disc, but they're not that pain, not much back pain. Or vice versa. That's the interesting part. But however, there are many patients in the intermediate disc degeneration, they're having a lot of back pain too. So really, my sort of research for the last 10 years, 20 years is really, can we do something at the early to mid stage of disc degeneration to rejuvenate the disc or whatever, to make the, or stop, getting into the, because when you get into the grade 5 and they're symptomatic, you have to do a fusion or, artificial disc. You cannot do a biological treatment or stem cell therapy at the grade 5, okay? So this gradual disc degeneration is important for treatment in the future. So as I told you, we know how to do the fusion before. Now with the MIS, we improve the technique, maybe hospital stays less and all that. But the still bottom line for discogenic back pain and fusion surgery is, at the end of the day, outcomes are still iffy, okay? So that's what you have to know. In fact, if you actually peruse the literature about how they do with a patient with a degenerative disc disease and pain, there are 3 level 1 study, prospective randomized study. First is that Swedish article. That's the first article in 2001 showing that fusion actually is better than control group. So this is when a lot of surgeons say, wow, we have now first-time evidence is better than, but they are not so fast, because there are 2 Danish study and British study came out and said if you really treat that control group with a good rehab program, the results are kind of similar. So it's still controversial. I'm not saying that fusion is bad. It's just that results are similar if you really push them with a good rehab program and all that. So that's why I'm still very conservative about treating back pain. So let me just finish out with some of the things I do. I did this study when I was in Wisconsin. When you have that disc degeneration, spine becomes more flexible or unstable. And then we actually try to learn about when the disc degenerate, what happens with biomechanics, kinematics. And we actually have this NIH grant to study in individual with back pain and asymptomatic volunteer with the different kinematic maneuver. And we have an ability to actually 3-dimensionalize their spine, like so. And you can see, even with axial rotation, there's no way you can get a good imaging with axial rotation with any technique except this 3-dimensional technique. So we know exactly what's happening to this space, facet joint, and we are studying these advanced 3-dimensional kinematic, and we are doing a study to compare back pain patient versus asymptomatic. What features stand out? For example, disc height was very important, differentiating symptom versus no symptoms. We are studying facet joint. I think facet joint is almost as important as a disc in terms of maybe etiology of pain. Bottom line is that what causes back pain? Is it muscle? Is it the facet? Is it the, I don't think it's one or the other. It's a combination of things. So it is for a physician to figure out, in this patient, wow, disc is predominant thing, so we treat that. Another set of patients, maybe a facet may be causing it, so you treat that. So that's why these kind of, I think, research is important to individualize back pain into different categories so that treatment can be effective. So that's basically the final goal. So just giving you some slides about the technology that you can measure the facet joint with. Osteoarthritis most precisely in the facet joint. And we have shown and published that facet joint space is important, differentiating back pain. All right, so I'm going to really finish out next 5 minutes about biological aspect of disc degeneration. So as you know, any tissue, whether it's a cartilage, bone, disc, it consists of cells and their matrix, right? So cell makes a matrix, and the matrix in the disc is like the disc consistency. So as a disc ages or degenerates, cell can become senescent or cells die. So cell is a very important component. The matrix they make, whether it's a proteoglycan or collagen, those are two main molecules we talk about. It can be decreased. And it's actually a metabolic process that we go through. The cell makeup, it degrades. It's a metabolism of this disc. Cartilage is very important. And if there's something wrong, it's too much breakdown of this matrix, disc will lose its matrix and this space will become narrow, right? I mean, that's one of the things. And there are many factors that contribute to this degeneration. For example, cigarette smoking will decrease nutrition. There are many papers, including mine, association with the disc degeneration and smoke. So obviously stop smoking if you want to have a healthy disc. Now, how about genetics? This is an interesting study. This is an identical twin study. Identical twins, right? Same genetics. One is actually a programmer for 20 years. Another one is a plumber. And if you look at the MRI scan, it looks identical. So bottom line about this paper is that the green bar, about 50 to 30%, is responsible by genetics. So if you have a bad disc, blame your mom and dad. I mean, that's one component. Of course, axial loading, job, and all those come into play, but the genetic is a big component. So genetic, whether it's, everything is genetic nowadays, stroke, brain, everything. So obviously there's genetic component, and we're trying to figure out which genes are responsible for this degeneration. There are many studies doing a population study trying to identify which genes. And if you get there, we can maybe target those molecules. I mean, that's in the future, okay? So we can find out which genes and do a genetic therapy, what have you. But that's 10 years down the road, 20 years down the road, we don't know. But genetic is a big component. No question about it. So this is kind of, a biochemistry slide showing that it's complex. It's not just simple one or two molecules. When you have this matrix, there are so many things that are involved to make the matrix better. We call that growth factor. Some what we call catabolic factors are some enzymes. So there's a breakdown and there's production. And the breakdown and production, the balance is very important to maintain this. So too much breakdown, this goes bad. So anyway, this kind of process we learned from many studies. And the idea, once again, is to biologically treat the intermediate disc degeneration. And really, in terms of biological treatment, there are three sort of options. One is inject these anabolic factors. If you inject into the disc this molecule we call growth factor, maybe it will make more matrix, makes the disc healthier. How about cells? I talked about cells, right? You can do cell transplantation. In fact, there are clinical studies going on, a cell trial. So if you inject stem cells or chondrocytes, maybe that cell is going to live in the disc. It'll make the matrix, make the disc better. These are all the ideas. So there are molecular treatment and the cell treatment. Gene therapy, I don't think that'll ever come to fruition because there's some safety involved with the gene therapy, not for this problem. So, I did a lot of studies and publications. The growth factors are very effective. There's one of the growth factor. This is actually a rabbit disc model. If you kind of puncture your rabbit disc will degenerate and MRI scan changes. And we published the rabbit disc model. And if you inject this growth factor called OP1, look at the MRI scan goes back to normal. And disc height almost goes back to 90%. So we can definitely make the rabbit disc back to almost 90% normal with just one injection of the growth factor. So it's not unique to OP1. There's another growth factor called GDF5, and this is a different company producing it. So based on our research at Rush, actually FDA is doing a clinical trial on these two drug study. And drug study takes 10 years to complete. So they're doing a safety study first, and who knows it's going to be finished and when. But it's not just a growth factor. This is a slide, some of the other molecules that other investigators and people are just one slide. So it can be so many things because as we know more about biochemistry, cell biology, there are so many things come up that can be beneficial or can be, if it's something bad, we can block those. So there's a lot of room for research, bottom line. And let me show you one slide that we actually published on resveratrol. You know what resveratrol is, right? Yes. Resveratrol is anti-aging, anti-oxidant. This is kind of cute study in that resveratrol is a key ingredient for red wine. So we found beneficial effect on the disc cells. So if you learn anything today, drink a lot of red wine. It's good for your disc. In fact, you can buy a resveratrol pill in the pharmacy, the vitamin store. So you can actually take a pill. So my wife asked me to take resveratrol once a day. Not for this, I think for anti-aging or something, So anyway, so it's kind of. So I talked about cell therapy. There are many candidates for different cells and stem cells. It could be allograft or so we've done some study on that. And this is a kind of, in fact, we did a skin cell. If you can turn a lot of cells with the right technology, go back to stem cell, you can make the disc. And skin fibroblast is one of them, and we've presented, not published yet. So really, this is final couple slides in that, we have an ability to make the disc look better on MRI scan, or disc height gets better, right? Either cell therapy or molecules. But is that going to translate into less pain or better function? Nobody knows unless we do the clinical trial, right? But at the same time, people are, including our group, is working at pain reduction strategy first. Because who cares, MRI looks bad. If the pain is less, patient can be more functional, they can exercise better. So pain reduction is very important in my opinion, because that's why patients are in my office, back pain. And there are some molecules relate to pain production. So if you can block those maybe pain molecules, maybe that's the strategy. Maybe we don't need to make the disc better, just block the pain. So, and then we know that discogenic pain is basically related to the little small nerves we call the sinovertebral nerves around that outer aspect of the annulus. So maybe we can target that. And in fact, that we actually have a discogenic pain animal model that we have developed and published. It's a rat model. In fact, how can the rat express pain? Actually, we are working with a pain anesthesia at Rush. You can actually do a straight leg imaging test on the rat. You can actually palpate that puncture disc, and rat will vocalize, okay? And then you can quantify this vocalization. So it's kind of interesting how the pain group, so we can semi-quantitatively assess their pain. How far are we going to get? I have no idea, but. So this is a final slide, really, because when pain is an interesting thing. Pain is like for 2-3 months, no problem, right? But if it lasts for 2-3 years, even if you take care of the underlying problem, patients don't do well. Everybody knows that. Chronic pain is not just a local disease, but it sends all that fiber into, it's a whole body brain problem. So the idea is that when you have a disc causing problem, let's intervene early on, before 6 months with minimally or less invasive or drink wine, whatever, to stop the pain so that it doesn't go into a chronic. In fact, that 80% of the pain, 80% of the costs related to back pain is for chronic pain, not for acute. So that's the idea, to prevent this chronic pain problem. So I think that obviously pathogenesis, all this research is interesting. For me, is 80% of my time is for patient care, but I try to do research and teachings, keep these things interesting. Hopefully I can contribute in the future to make something better for these discoordinated patients. So thank you very much.